Welcome to Dr. Balga's podcast for the Curious Doc. Today is Feb 7, 2026. This video is on a New England Journal of Medicine review article titled The Inherited Basis of Coronary Artery Disease, published on Feb 4th, 2026. That's about 3 days ago. Inherited Basis of Coronary Artery Disease. What is the inherited contribution of CAD to CAD? Genetic factors substantially influence CAD risk through rare monogenic variants and numerous common polygenic variants. How common are monogenic causes of CAD? Monogenic causes occur in approximately 1 in 250 people and usually involve markedly elevated lipid levels. What is familial hypercholesterolemia? FH is an incompletely dominant monogenic disorder causing lifelong elevation of LDL cholesterol and premature coronary artery disease. Which genes most commonly cause FH? Pathogenic variants most often affect LDL receptors, ApoB or PCSK9, impairing LDL cholesterol clearance. How prevalent is heterozygous familial hypercholesterolemia? Heterozygous FH affects about 4 in 1,000 people in the general population. What clinical features suggest familial hypercholesterolemia? Severely elevated LDL cholesterol, premature coronary artery disease, tendon xanthomas, or xanthal asthma raise suspicion of FH. Why is genetic confirmation of FH important? At similar LDL levels, genetically confirmed FH confers 2 to 3-fold higher CAD risk. What are other rare monogenic CAD conditions? These include autosomal recessive hypercholesterolemia, cytosterolemia, and pseudoxanthoma elasticum. What's the role of nitric oxide pathway genes? Variants in genes such as NOS3, GUCY1A1, and PDE5A are linked to premature coronary artery disease and high blood pressure. Do rare variants explain most CAD cases? No. Rare variants explain few cases. Common variants dominate population level risk. What defines polygenic risk for CAD? Polygenic risk reflects the cumulative effect of hundreds of common variants with small individual effects. How many CAD loci have been identified? Genome-wide association studies, GWAS, have identified 346 loci associated with CAD risk. How is polygenic risk distributed? Polygenic risk follows a normal distribution across the population. How much higher is risk in the top polygenic risk group? Individuals in the top 5% have 3 to 5-fold higher coronary artery disease risk than average. Is polygenic risk independent of family history? Yes. Polygenic risk predicts CAD independently of reported family history. How does PRS or polygenic risk score improve risk prediction? It refines risk estimates when combined with standard risk clinical risk scores. How is PRS combined with clinical risk? The relative risk from PRS multiplies with the absolute risk from clinical scores. Who benefits most from polygenic risk score assessment? Younger adults, intermediate risk individuals, and those with premature coronary artery disease benefit the most. What are the limitations of current PRS? Performance varies by ancestry, scores lack standardization, and guidelines have not fully adopted PRS. Does PRS guide treatment decisions? Polygenic risk scores may support earlier or intensified preventive therapy when clinical risk is uncertain. Can lifestyle offset genetic coronary artery disease risk? Healthy lifestyle behaviors substantially attenuate CAD risk even in those with high PRS. Do statins work better in high genetic risk? Statins and PCSK9 inhibitors yield greater absolute risk reduction in high PRS individuals. What LDL targets apply in familial hypercholesterolemia? Adults with familial hypercholesterolemia should target LDL cholesterol below 70 milligrams per deciliter for primary prevention. When children with familial hypercholesterolemia When should children with familial hypercholesterolemia be treated? Statins may be initiated in childhood when LDL cholesterol remains persistently elevated. Is homozygous familial hypercholesterolemia severe? Yes. Homozygous familial hypercholesterolemia is life-threatening with CAD, often developing in childhood. How does genetics inform new therapies? Genetic validation increases the likelihood that drug targets will be clinically effective. Which lipid targets are genetically supported? LDL receptor, PCSK9, NPC1L1, ACLY, and LP(a) are genetically validated CAD targets. Why is lipoprotein a important? LP(a) variants strongly associate with coronary artery disease, and targeted therapies are in clinical trials. What is Mendelian randomization? It uses genetic variants to distinguish causal risk factors beyond biomarkers. Which biomarkers are causally linked to CAD? LDL cholesterol, triglycerides, high blood pressure, obesity, diabetes, and LP(a) are causal. This is in a nutshell. Read this terrific review in the New England Journal of Medicine, published this week online. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.